Hello, welcome to the ICML Knowledge Center. My name is Katia Pagnano. I'm from University of Campinas, São Paulo, Brazil. And I will do this topic about how to implement TFR in resource-constrained countries. This topic I would like to thank the International Chronic Myeloid Leukemia for the invitation. And this topic has two parts. The first one, I will talk about the Latin America perspective. What are our challenges in TFR for CML patients? And after me, Dr. Hematology, which is a professor and head of the Department of Medical Oncology of Sri Ram Cancer Center in India, will talk about his own experience and the perspective for treating patients in resource-constrained countries. I would like to start about access to TKI in Latin America in 2001. We have many different conditions in Latin America. We have public and private systems. 50% of our countries have access to second generation TKI, and most of them have access to all TKIs in the private system. Argentina, Chile, and Costa Rica have access to frontline bosutinib, but not Brazil and other countries. And there are some countries that need to get TKIs through charitable foundations, like the Max Foundation, which helps Paraguay and Guatemala, and Fundación Alas de Vida in Nicaragua. 5 countries do not have access to second generation TKI in the public system, and 13 have at least one. Only 2 countries have access to ponatinib and bosutinib. So I will show this table here. At the beginning of the year, in March, we did a review about challenges in treating CML patients in Latin America, and Virginia Bello from Colombia did this survey with hematologists. And what we can see that, for example, we have in Argentina, they have access to all TKI in first, second, and third line. But in contrast, Bolivia don't have access to TKI in the public health system. In Brazil, we have imatinib in first line approved for public health system, and we have nilotinib and dasatinib in second line. Another problem is access to bone marrow transplantation. As you may notice here in Nicaragua, on the right side in blue, Nicaragua, El Salvador, Dominican Republic, they don't have access, and also Bolivia, to bone marrow transplantation. So this is the reality. There is a discrepancy between the countries, and we share many difficulties to treat our patients. So there's the barriers for treatment, also barriers for TFR implementation in Latin America. Latin America is a large region. The public policies are different between the countries. We have a problem about monitoring, BCR monitoring, because for TFR implementation, it's essential to have good quality PCR, and this is not yet reimbursed in most of the countries. So this is a challenge. A couple of years ago, we did a pharmacoeconomic study about the financial impact of imatinib discontinuation in Brazil. So we analyzed 151 patients treated between 2010 and 2011 with imatinib first line, median age 45 at diagnosis, and followed these patients for 8 years. And we see that 37% of the patients achieve a stable AMR 4.5 in a median time of 71 months. And from these patients, we did an estimative of costs if these patients stayed on treatment without interrupting until the life expectancy of 75 years. It would be about 29 years of continuous treatment. So for this analysis, 25% were eligible, and we estimated around $9 million the cost of the treatment until this patient dies. On the other hand, if we put these patients in a discontinuation program, estimating that 50% of these patients would relapse, we have considered the cost of the treatment in the relapsed patients, also considering the PCR test for 29 years. We would save about more than $1.5 million if we do this strategy. it would support the test for additional 219 patients for 29 years, or 2,000 tests a year. So the discontinuation, besides leading with the adverse chronic events for the patient, it's a good thing. It has also an impact, a good impact in countries. We have some experience in clinical trials in Brazil. The first experience was an industry-sponsored trial, the NSTOP trial from Novartis. 26 patients were randomized in 7 Brazilian centers. And this was the first trial that we could conduct in Brazil. After that, we had 2 university trials. One was conducted at my university, University of Campinas. We recruited 32 patients, and the other one at University of São Paulo by Dr. Israel Bendit, 31 patients. And ongoing, we have a discontinuation trial, which is based, has a design similar to the DESTINY trial, with a de-escalation period of 6 months before interrupting. This study is ongoing, and we aimed to do this study, a national study, but we are still trying to get funds for this research. I will summarize the 2 main studies that we have recruited. It was finished. The one is EDIPIL trial. We included patients treated with imatinib for 3 or more years, and that have a stable major deep molecular response of MR4.5 for 2 years at least. These patients were treated with imatinib and pioglitazone for 3 months, and then they went to the discontinuation phase. In the first year, there was a month monitoring. In the second year, every 2 months, and then the third year beyond, every 3 months. The trigger for imatinib reintroduction was loss of MMR and loss of MR4 in 2 samples. So this is the inclusion criteria summary. The ECOG, aspartate, transaminases, and bilirubin was required because of the pioglitazone use. And we excluded patients with severe organ dysfunctions, fluid retention, osteoporosis in treatment, and also patients in advanced phase and have previous resistance and BCR-ABL mutations previous to the discontinuation, and previous allogeneic bone marrow transplantation as well. These are the main characteristics of our patient group. The median age at study entry was 54. Most of the patients were male. We have 50% of the patients with low SOCO score, and predominantly B382 BCR-ABL transcript. The time from diagnosis to study entry was 123 months, and the duration of imatinib therapy of 102 months. Patients were previously treated with Hydrea, with interferon alpha, only 6 patients, and 1 patient with autologous bone marrow transplantation. The most frequent comorbidity was hypertension, hypercholesterolemia, and hypertriglyceridemia. And 81% of the patients were treated with generic imatinib. And the duration of MR4 and MR5.5 was 93 months. So this is the result of 3 months of our trial. We have 60% of treatment-free remission at 3 months. And when we had stratified by SOCO score, we had 81% of patients that in low-risk patients. On the other hand, patients with intermediate and high SOCO score had only TFR of 33%. Another positive impact was the duration of the treatment. Patients who were treated for more than 9 years, they had the best TFR curve of 78%, and patients with less than 9 years of treatment, 43%. This confirms the findings of other studies. Withdrawal syndrome, interferon use, and also gender did not impact on the TFR result. In the University of São Paulo trial, the results were similar. On our left is the molecular relapse-free survival curve. It was 54% after 24 months of discontinuation. And this study included patients that had MR4 before discontinuation as well. But we can notice in this graph on our right that patients in blue or patients that discontinued in MR4.5, they had a lower rate of relapse compared with patients that discontinued in MR4, which has 62% of chance of relapsing. So in our population, the best results were achieved in MR4.5. I'm also going to show you the results of the Argentina STOP trial. This study is presented their preliminary results in the last ASH meeting. And here we can see on the right, the molecular relapse-free survival of 80% in 6 months. And also they have a positive impact of the duration of the deep molecular response. So patients in blue, the TFR is superior than the patients that has a less time of treatment before it's continued. Before the pandemic, we have had a meeting in Buenos Aires with the late leukemia group, and this meeting was to do what I'm going to show you now. That was the recommendation of the LAUNET expert panel. So I'm going to show you this panel that was conducted by many countries of Latin America, and we have some recommendations adapted to our reality. This, as I'm going to show, is not so many different from the other guidelines, but has some particularities. So this panel recommended that the TKI duration should be at least 5 years before discontinuation for any TKI. The deep molecular response duration was MR4.5 for 2 years, confirmed by 4 tests, and only recommendation for discontinuation in patients in chronic phase, like other guidelines, and typical BCR-ABL transcripts that are measurable by quantitative PCR. We only recommend discontinuation in our population for patients that have switched to other TKI by intolerance, not by resistance, because the rate of success in a population with previous resistance is lower than a patient who had previous intolerance. The optimal frequency after discontinuation, we recommend monthly PCR during the first 6 months after discontinuation, because during this period, we observe the most relapses occur in the first 6 months. And in the second semester, every 2 or 3 months, and then every 3 months. We don't know so far which is the best time to make this interval longer. The definition of molecular relapse, the trigger for starting TKI is loss of major molecular response. It's a safe trigger. And the monitoring after TKI initiation should be every 2 to 3 months after TKI reintroduction. We know that most patients achieve the major MR4 after a median time about 3 months. So we can wait until 6 if the patients do not regain MMR. We should do all the procedure for looking for mutations and for looking for resistance. Regarding withdrawal syndrome, it may happen after discontinuation. So in the recommendations, there are all the symptoms, all the description of the withdrawal syndrome, and that it should be talked with the patient about this before considering TFR. And we should monitor these patients about osteoarticular symptoms. Additional labs that we should do after discontinuation are the monitoring of glucose and lipid profile. After we stop imatinib, we see an increase of glucose levels and lipid profile in some patients. And after interruption of nilotinib may occur, there be an improvement of glucose levels. So we should monitor this after interrupting treatment. We also discuss about psychosocial situation of the patient before TFR. If the patient has to know the chances of discontinuation, Patient has to know that he has to do a straight follow-up before discontinuation to detect earlier the molecular relapse. And this has to be made very clear that the monitoring is for lifelong. It doesn't matter if patient is using or not using RTKI, because TFR does not mean a complete cure of CML. And during monitoring, the physicians should also be alert of anxiety, and if necessary, they should seek professional psychological help if needed, if the patient needs. Regarding pharmacoeconomic considerations, you saw in my presentation how important it is to have numbers to evaluate what are the costs of our treatments, and to show to our governments and to make projections about the cost of the test, the cost of the treatment. This certainly will make TFR is feasible and safe for all our patients. So in this table, I would like to summarize the Latin America and Leukemia.net recommendations. So in our left is the LAUNET 2001. We recommend 5 years for all TKI. Leukemia.net recommends 5 years at least, but 4 years for second generation TKI. So this is a small difference. For molecular response, our trigger to discontinue treatment is MR4.5 for 2 years. Leukemia.net recommends MR4 for 3 years and MR4.5 for 2. We choose this MR4.5 because we thought it was easier for all physicians and a safer trigger for discontinuation. Regarding disease phase and BCR-ABL transcript type, it's the same. Previous resistance is also not recommended by the European Leukemia.net, and the trigger for reintroduction of treatment is the same, loss of MMR. And in the monitoring after discontinuation, the only difference is that in the second semester for months 6 to 12, we will do this monitoring every 2 or 3 months, and the Leukemia.net recommends in every 3 months. And it's of consensus that the access to high quality PCR is an essential part of the monitoring, and that it's impossible to do TFR without proper monitoring. In summary, we have seen that there are many challenges for incorporating TFR in clinical practice in Latin America. TFR is feasible in real life if the minimum criteria are met and monitoring available, and adequate selection of the patients increase the chance of a successful TFR. So if adequate standardized RT-PCR is not available, the LAUNET group strongly recommends against TFR attempts. I'd like to thank all the people from the LAUNET group for the development of these guidelines, people from my center, from the research team to conduct the TFR discontinuation trials, the support of the International Chronic Myeloid Foundation, and also to our CML patients. That's what we do. We work for trying to improve your life and your chance of cure. Thank you very much.